Hi, everyone. Welcome to the show. I'm your host, Dr. Dean Mitchell. As our regular listeners know, this is where you can get the best medical information anytime, anywhere. So sit back, relax. You're about to enter the Smartest Doctor in the Room podcast. Now, blood pressure and our heart rate is not something we typically give any conscious thought to. Why? Because it's controlled by a large degree by our autonomic nervous system. This is a branch of our nervous system that is independent of our thoughts, I think for the most part, since our conscious brain is engaged in thinking and acting. Most of the time, though, when a patient sees a doctor regarding what we call these vital signs, it's usually for high blood pressure, or it could be in regards to an abnormal heart rate, such as an arrhythmia like atrial fibrillation. But there's another side to this concern with blood pressure and heart rate of late, and the conditions are called postural orthostatic hypotension, a very long word, which essentially means when you change positions from sitting to or from lying to standing, you get low blood pressure. And also its sort of cousin, postural orthostatic tachycardia, where in this case, changing positions leads to a very fast heart rate. Now, this has become an extremely timely problem because since the onset of the COVID pandemic, I can tell you personally, in the last 4.5 years, I have seen in my practice more patients with POTS than I saw in my prior 25 years of practice. So the big question, which we will get to at some point, is why is that happening? My guest today, Dr. William Cheshire, is and has been really one of the OGs, as we call them, original greats. He's an expert neurologist in this area of autonomic medicine for decades. He is a professor of neurology at the Mayo Clinic in Jacksonville, Florida, as well as the division director of autonomic neurology and a chief editor of the Journal of Autonomic Diseases and a past president of the American Autonomic Society. So you know we're talking to the right person. I recently read a brief but excellent article that was published in a JAMA, the Journal of American Medical Association. He gave a sort of little primer summary on tilt table testing, which we'll get into, which is the gold standard for evaluation of postural diseases. So I am super pleased and honored to welcome Dr. William Cheshire to the podcast.
Well, thank you, Dr. Mitchell. It's a pleasure to be here. And I'm really glad that I don't have to be consciously thinking about how to regulate my blood pressure and heart rate and body temperature and all these things from moment to moment, because just like you, there are other things I'd rather be focusing my attention on, one of them being my patients. But patients do come to me who are having difficulty with how their autonomic nervous system is working along these lines. Autonomic neurology is a subspecialty within the field of neurology, but there are also other specialties that are involved in this field: cardiologists, internists, endocrinologists, pediatricians, many others. And the overlap of these specialties tells you something about the nature of autonomic medicine, in that it's integrative, it's multidisciplinary, and it really demands a holistic response to the patient. The autonomic nervous system infiltrates every organ system. It's everywhere in the body. It has a role in coordinating the different internal activities of the body and maintaining a stable homeostasis so that we can be comfortable in life. But it also coordinates our response to stress. Stress might be, well, here in Jacksonville, it's 95 degrees. I don't know what it is up there in New York.
No, we're having a very pleasant day in New York for a change.
Nice. But you've got to have a functioning autonomic nervous system to respond to heat stress. And people get into trouble during hot days like this if they exercise vigorously outdoors and don't take care to hydrate adequately or to rest when they get overheated. And I see patients who lack the ability to control their temperature and may lose the ability, for example, to sweat. And if you can't sweat and you go out in this heat and exercise, you could be in trouble really quickly.
Yeah.
So blood pressure is another common concern. As you mentioned, we're used to thinking of high blood pressure. Well, There are lots of patients who have trouble with low blood pressure.
Yeah, we're going to get into that. I want to ask you first, because again, you do really explain things really well. This is going to be a very easy podcast for me today. I want to step back a second because I made it extremely simplistic, but it's really not. And I even in preparation for this podcast, I had to go back to some of my neuroanatomy, believe it or not, like pictures and textbooks, because I really wanted to refamiliarize myself. But for our listeners, I think what I'm going to say, the simplest explanation of understanding the autonomic nervous system, I guess they know the terms, fight or flight, which is with the sympathetic system, and sort of like the yin yang, parasympathetic system is the calming part of our system. Could you maybe take it a little bit further? I know you started to do it to explain. I mean, because I think most patients, listeners could understand the way what we call our motor and sensory system works. We know from our brain, we get a signal. If we touch a sharp object, it sends, impulses from the extremity to your brain, and you feel pain. And the same way too, your brain, when you decide whether it's athletics or do anything physical, your brain is sending a signal quickly from a motor neuron to that limb or wherever to move and do something. But how would you explain to the listeners this autonomic nervous system? And I know it's kind of complex, but I think if anybody can do it, you can. So
It's complex, and we, like all specialties, have our complicated terminology. The sympathetic and parasympathetic systems are complementary. They help to achieve an equilibrium. We have two cats at home. When they're hungry, their sympathetic nervous systems are active. They become predators. They're running around, and you can see how they behave in the wild. And then once they're fed, the parasympathetic nervous system comes in. They go and take a nap, and they are calm and relaxed and very happy. So that's just one aspect of these two arms of the autonomic nervous system. And in reality, it's much more complex, but it helps to have kind of an overview of these two competing systems. They're not at war with one another, but a relative balance in these two systems helps us to respond to the situations in life.
The thing also that struck me from looking at some diagram pictures, it just reminded me again, and maybe this will help the listeners as well too. Again, when we think about sensory and motor neurons, we're typically thinking of, these nerve pathways going from the brain to a muscle. And I think with the autonomic nervous system, which is so fascinating, and we tend to really forget this a lot too, is that these nerve pathways are going to organs like the pancreas, the liver, the stomach, right?
Correct. I just lost your signal for a moment there. Still no signal at my end.
I'm still here as the producer, so I'll make sure that it gets back on track. We'll wait for him to come back on, and then.
Okay. Couldn't do this without editing.
Hi, Dean, I'm here. So just go ahead and pick up where you left off, and I'll be sure to edit this part out, okay?
Oh, God. Hi, I'm so sorry, Dr. Cheshire. I think it's from my end, which is weird. Can you hear me?
Yes.
I'm so sorry.
Back.
I think they're gonna have to edit this part. I think my internet connection, because I could see from my phone, was going dead. This is very weird on a landline. I wanted to back up for a second. I think I might have gotten cut off. That what I was saying was that I think the listeners could understand. When we think about motor neurons, a nerve pathway going from our brain to an extremity, and the same thing with a sensory neuron. If we touch a sharp object, that nerve pathway goes from the extremity to our brain. But the autonomic nervous system, using the term we use in medicine, innervates. The supply goes to organs, the heart and the stomach. I mean, you don't have a motor neuron going to the heart that I know of, but it's the autonomic nervous system, right? Is that correct? That's innervating
Yes.
these organs.
Yes, these nerves go to all the different organs in the body, including the blood vessels, the heart, the bladder, the sweat glands, um, and um, and so in the same way, there's a response that's initiated by the nerve, and then there's feedback that goes back to the brain to try to keep the response at an even level. So there are some autonomic disorders where the autonomic responses become exaggerated because that feedback system is there's a missing link, and there may be inappropriate input coming back to the brain, so the brain doesn't know what to do, and you have an exaggerated response. And these people might have, for example, surges of high blood pressure or high heart rate. In other cases, there's a defect in that connection, and there's an inadequate autonomic response, and so that person might have an abnormally low blood pressure. That's going to be most manifest when you're standing up under gravitational
Yeah,
stress.
Do you have any control, or do we have any control over this? Again, like some of my patients are very into, and I do functional medicine, so they'll try to meditate or listen to music. I mean, do some of these things have an impact on the autonomic nervous system? I mean, can we have some control over this supposed area that we aren't supposed to have control over?
Yes and no. We can have some control over it, and we can learn techniques to relax and to try to calm sympathetic responses if they're not necessary, if you're not in a fight or flight situation. But we wouldn't want to have complete voluntary control over the autonomic nervous system. There would be too much for us to be attending to it, and that would be overwhelming. So there's a lot of it that's actually inaccessible to our conscious awareness.
Okay. I want to get into, again, two of the things that are in your specialty. And as you mentioned, it's very interesting because, a lot of these cases that I've been even seeing too with postural orthostatic hypotension and POTS, with the tachycardia, they're seeing a myriad of doctors. Unfortunately, it's very hard to find specialists in the area. They'll find a cardiologist that might be interested in this area versus heart disease. Sometimes they'll see a neurologist. Sometimes they see rehab doctors. Could you define for the listeners a little bit, the clinical criteria, we would call it, for the diagnosis of postural orthostatic hypotension, as you know, based on blood pressure and heart rate?
Yeah, so I think you're referring to POTS, Postural Orthostatic Tachycardia syndrome.
And hypertension, both. It could be, yeah.
Right. So which is a different entity than orthostatic hypotension.
Okay.
But both categories basically have difficulty standing up. So as a neurologist, if I see someone who tells me they have trouble standing, I want to know, well, are they what symptoms do you experience when you're standing up? Is there pain in a joint? Maybe it's a hip, knee, or ankle problem, or a foot problem. Could it be a muscle problem, or the legs strong enough to support your body weight? Or could it be a problem with balance? Are you receiving good sensation from the feet to tell you where your legs are in space? Or could it be an inner ear problem so that your sense of balance is off and you're feeling vertigo and feeling like you're moving, rocking, or spinning? If it's not any of those things, then what I typically see in my practice are problems with blood pressure or heart rate control when you stand up. So for any of us, when we stand up, the force of gravity shifts our blood volume downward, and the blood wants to settle in the belly and in the legs. Animals, for the most part, don't have this problem because they don't have as much blood volume in the legs. This is a problem that's unique to humans.
Well, because they're not erect, right? They're sort of horizontal.
Yeah. Giraffes, horses, they have very thin legs. Very little blood supply is needed in the legs.
Right.
But humans are different, and as much as a liter of blood might be shifted downward.
That's a lot.
That means less blood flow available to the heart and brain and other organs. So the body has to do something to compensate for that shift. And most of that work is done by the sympathetic nervous system, which then kicks in and sends signals to the heart to beat faster, to pump more blood, and most importantly, to the blood vessels. The peripheral blood vessels will then constrict so that there's more blood available to return to the heart. For most of us, for healthy people, that adjustment takes a few seconds, Within 15 seconds, things are at equilibrium again when you stand up, and you might not feel anything, or you might feel just a momentary lightheadedness. But for patients with autonomic disorders, they can have persistent symptoms, making it very difficult to keep standing up. And when will those symptoms be more pronounced? Well, under other conditions that might stress the system. If you're dehydrated, if you're out in hot weather, because hot weather dilates the blood vessels further and there's more pooling of the blood. Taking a warm shower can be difficult for patients with POTS, for example. That heat stimulus, and you're standing still. When you're standing still, you're not using your leg muscles as much. And the leg muscles are one of the important mechanisms for compressing the veins and helping the blood to return to the heart.
These are great clues, what you're pointing out. I mean, because think about it too, like when you get a history with somebody that, again, if it's a little bit vague and they're worried about why are they unsteady, and they say, well, I go in the shower and I start to almost feel like I'm going to pass out. That is interesting. I mean, again, that's a good diagnostician, catching some of the clues. The other thing too, just I'm sure you've heard this a lot of times, I find fascinating is that, again, when these patients, they're standing in a line for a movie, or well, back in the day for a movie or a show, that they start to get like dimming of their vision.
Yes.
It almost feels like, the lights are going out kind of thing.
Yes, the vision can turn gray, or you can have tunnel vision, or it can go completely blank.
Mm.
Other symptoms could be lightheadedness, a fast heart rate, a sense of brain fog, not being able to think clearly, or just fatigue. And one way we can know if this is an orthostatic disorder is, do the symptoms improve if you sit down or lie down? If they immediately improve, then that's a strong clue.
Okay. Let me ask you about the diseases, and we'll talk a little bit about some medications that make patients vulnerable. As I mentioned in the introduction, I mean, COVID, it really has blown me away how many cases we're seeing of POTS in particular. Another area in my specialty of immunology and allergy, I'm seeing a lot of mast cell activation syndrome. And some of these are associated with something you might be familiar with, Ehlers-Danlos syndrome, EDS. Again, a population where I'm seeing a lot of these POTS issues. And before all of that, for years, I was seeing to some degree two patients that were diagnosed with obviously the complex condition of myalgic encephalitis, or better known as chronic fatigue syndrome, and of course diabetes is the really well-known one. So just out of curiosity, again, it may be too early to know, but do we know why patients with COVID infections are getting? I mean, because we know that it infects like primary monocytes and stuff like that too. Like, why is it affecting the nervous system this way? Is there any clues yet as to why that's been happening? And then we're going to get into a case that actually you wrote about in one of your papers that I think it was in the JAMA article. But anyway,
there's so much that we could talk about. When COVID first hit, those of us in neurology were recalling what we've read about the 1918 influenza pandemic, and there were cases of Parkinsonism that developed after that pandemic.
Wow.
So we were wondering, since this COVID virus can block the sense of smell and taste for some people, we know therefore that it can get into the nervous system. When we were worried, are we going to be seeing Parkinson's disease develop after COVID? Well, fortunately, we haven't seen that. I've heard of some very rare cases, but we've seen plenty of other sequelae. Among them, stroke. I've seen patients with spinal cord lesions developing after COVID, and many other things. But we are seeing a lot of cases of POTS, patients with postural tachycardia and long-lasting fatigue after having COVID, and some of them after having just a mild case of COVID.
Right.
And they're all different. In my experience, I see a lot of these patients. Some of them have orthostatic intolerance, the broad term that we use for difficulty standing, and yet have normal blood pressures and heart rates when we measure those things when they stand up. So things are more complicated than we first realized. I think we are seeing more cases of POTS. Part of it also is that there may be more awareness. And when we see patients with fatigue after a viral infection, we're more likely to check these things now that we understand POTS better.
Do you think it's more of a sympathetic, parasympathetic? Do you think there's also, I mean, again, I know this is early on, like even an area of the brain, whether it's the, what do we call, like the pons or the brain stem or something that's getting inflamed, or nothing has shown up yet on MRIs or any kind of testing that helps kind of zero in where the issue is?
There's no one test that gives us an answer to that question.
Mm-hmm.
A lot of us would like to have an answer to that question.
Yeah.
We do know that in POTS in general, it can develop after any virus infection.
Really?
Epstein-Barr virus is one example. So we know that a virus can trigger it. And because of that, we suspect that in some cases it's autoimmune. But there's not been good evidence at this point for a specific antibody that's abnormal in POTS cases.
Mm-hmm.
We do know that about 2/3 of POTS patients are hypovolemic. They have reduced blood volume compared to controls. So we know that increasing the blood volume by adding salt to the diet or supplementing electrolytes with sports beverages or other means is very helpful for a majority of patients. There's more to the mechanism of this than we fully understand yet. And so we need more research.
Yeah, no, absolutely. And but I think even some of the small pointers that you're mentioning are simple and easy for patients to do. Again, we're always telling them to hydrate. And I always tell them, also when I have patients that run low blood pressure, especially a lot of women that I see with chronic fatigue in my office, I tell them, enjoy your food, salt your all your meals. I mean, I wish, me, I have borderline blood pressure. I can't have that advantage, but for them, enjoy yourself. Okay, I want to go into one of the cases. Actually, it was the case. This one is going to be from the JAMA case, and I'll do a quick summary because I really want to focus on a little bit the evaluation and treatments that you recommended in the article. So, for the listeners, this was an interesting case. It was a 43-year-old woman who had fatigue, palpitations, shortness of breath, chest pain, lightheadedness, and nausea. And it started 1 month after the COVID-19 infection. So she didn't have any of this prior to the infection. Her blood pressure that Dr. Cheshire had gotten was lying down, or as they say, supine, was 120/80 and a slightly fast heart rate at 90. But when she was standing and they checked her blood pressure 1 minute after standing, her blood pressure stayed about the same. It was 124/80, but her heart rate went up to 119, which is almost 20 points higher. And in his evaluation, they did blood testing looking for hormonal issues. The thyroid was normal, cortisol, which we will talk about maybe in a little bit, to see that can affect blood pressure. Her cell count, she wasn't anemic. That was all normal. And they also checked what was called EKG to make sure there wasn't any type of arrhythmia. And other pulmonary cardiac testing was normal. There was actually a little bit even more extensive cardiac testing done, but I don't want to really get into that. But the key thing was in your evaluation, which I'm sure in your center, not a lot of places don't have this. You did a tilt table test. So maybe you'll explain that because it was positive in this patient. So maybe you could explain a little bit about what goes on in the tilt table test and how important is it? Because, not obviously every medical office or center even has this available to them and they're experts at knowing how to do it. So how important is this test to confirm POTS versus just taking blood pressure and pulse, heart rate in various positions in, let's say, my office or another doctor's office?
Well, first, in the way of background, the editors of JAMA invited us to write this manuscript to describe the tilt table test.
Okay.
And I thought that what would be most useful right now, given our post-COVID climate, would be to present a representative case of POTS developing after a case of COVID, just to raise awareness of the issue.
Absolutely.
So we chose a representative case, and some of the other testing was mentioned just to convince the audience that it wasn't something other than POTS, because there are many things that could cause fatigue when standing, or a cardiac condition, many other things. So we wanted to highlight how the tilt table test works, what's the rationale. And as you pointed out, when this individual was tilted up, to an angle of 70 degrees. And we do this in our lab without pharmacologic provocation.
Okay.
Some labs will give nitroglycerin or isoproterenol to make the stimulus stronger.
Mm.
The blood pressure remains stable, but the heart rate rose beyond a normal level. Now, a normal increase in heart rate for an adult would be something less than 30 beats per minute above baseline. Anything above that, if it's sustained, we would count that as POTS. For a younger person under the age of 20, a higher heart rate could be normal. And so the cutoff for an adolescent would be 40 beats per minute above baseline. So you're correct. Not all laboratories will have a tilt table, and this is our gold standard for diagnosing POTS. But if you don't have a tilt table, you can gain a lot of information. I think some would say sufficient information from what's called an active stand test. So you would measure the same things, the blood pressure and the heart rate, lying down and then standing. And standing is going to be more representative of what someone does in their daily life, right? Most people are not
Right.
spending the morning on a tilt table.
Well, is the
Hopefully.
tilt table also done just like sort of for safety reasons? I assume, or no? Or is it just different angles of the tilt table, or because there's obviously a big difference versus sitting down, lying down, and then going sitting at let's say 45 degrees and then standing. The tilt table, is it does it go like 10 degrees at a time or something? I mean, what's the key difference?
There are different methodologies for using a
Yeah.
tilt table. We bring it right up to about 70 degrees. It
Oh, you
takes
do.
about a minute to reach that angle. The main difference from standing is that you're unloading the legs. You don't, the patient who's suspended on the table doesn't need to be pushing with the legs to maintain the upright posture. So
Okay.
there's more opportunity for the blood to pool in the legs. In that sense, it's a stronger stimulants. But there are also subtle differences in the physiology. When you stand up without a tilt table, there are other reflexes that come into play, and there can be more pooling in the legs under that situation. So the two are different, but if you're wanting to reproduce what happens in someone's daily life, a standing test can be very useful, and it may be all you need, but you have to do it very carefully. The supine measurement should be done after several minutes of rest in order to obtain an adequate baseline. Because for some patients, it takes a few minutes for the blood pressure and heart rate to settle down. And then during standing, I will typically check the blood pressure and heart rate over 1 to several minutes and monitor them for symptoms. And the heart rate in a normal person will be up and down when you're standing up. And it's important not to focus your attention just on the peaks or the troughs, but to try to get a sense of what the average is, because it's the average heart rate upon which normal values are based.
Would you find that the symptoms come on before the change in the heart rate or blood pressure, or it's really vice versa? Because I can imagine people getting scared. Like, well, they're probably fearful that something's going to happen. So they start to panic and, or is it typically, most of them are, okay until the actual physiological changes start to happen?
Some patients will feel very anxious when the tilt table first goes up because it's an unfamiliar stimulus. And then things kind of equilibrate.
Okay.
At the bedside, when I measure these things, there's less of an anxiety component, or at least no more than just during a routine doctor's visit, because there are a lot of other reasons to be anxious. Um, but usually the patient may feel lightheaded for a few seconds, and then that kind of goes away. And it's
Hmm.
how they feel as they continue to stand that is a clue to me. And there may be physical signs as well. Someone with orthostatic intolerance with POTS may shift the weight from leg to leg because that activates what we call the muscle pump. The leg muscles are contracting and helping to squeeze the veins and return the blood to the heart. Some patients will have vasomotor changes. And as an allergist, you might see this in your practice where the feet or the legs may look red or maybe splotchy as a sign of vasomotor instability in the legs.
Hmm. Okay. I want to ask you now that you mentioned in the article, because I found this very important too. because there's also a wide range of how these patients get treated. So if you don't mind, you mentioned a few medications for this particular patient, so I want to go through them and ask the logic behind it, and how you decide on what to give. So one of the things you mentioned was a medication called midodrine, which is a stimulant. You mentioned to give about 7.5 milligrams 3 times a day. What is that supposed to do? Now, again, and would this be the same? Because you mentioned in this case for postural orthostatic tachycardia, would it be? I know it's also used for the postural orthostatic intolerance or hypertension. So, what are you hoping that it's going to raise the blood pressure temporarily? Is that the goal with this?
Well, midodrine is not actually a stimulant, but it's a vasoactive medication. It's a mild vasoconstrictor.
Okay.
We used to use ephedrine years ago as a medication to treat orthostatic hypotension. Midodrine was developed as a safer alternative. It has fewer side effects than ephedrine, and it doesn't elevate the blood pressure as much. It's indicated for treating neurogenic orthostatic hypotension, but we also found it to be useful in some patients with POTS, not all, but in some patients do quite well with it. It essentially constricts just a little bit the arterioles and to some extent the veins. So it reduces the pooling of blood. And the goal is not to elevate the blood pressure, but to keep the blood pressure from falling in orthostatic hypotension. But in patients who have blood pooling, it also seems to help with many patients with POTS. So that's the rationale. The important thing to keep in mind if you're using it to treat orthostatic hypotension is not to lie down within a few hours of taking it, to wait for it to wear off.
Because otherwise your pressure will go too high in some cases, correct?
Right. It can elevate the pressure when you're lying down. That's a concern for orthostatic hypotension, not so much for POTS.
Yeah, that's a great point. What about now I wasn't familiar with this one. I mean, not in this light. I think I remember it was used for myasthenia gravis, something. Pyridostigmine. Why would that be recommended for this patient?
Yes, pyridostigmine. That's another drug that was initially developed for treating orthostatic hypotension. We think of it as a smart drug. What it does is enhances ganglionic transmission. And so it is used to treat myasthenia gravis at the neuromuscular junction, but it also works at the autonomic ganglia junction, which is part of the sympathetic circuit. So that sympathetic flow through the autonomic ganglia is activated when you stand up, and the pyridostigmine enhances that flow. So the drug is going to be active on that system when you're standing up. So it can improve orthostatic tolerance in some patients.
That sounds like a great suggestion. I have not seen that in any of the patients that I've been seeing that have been being treated for this up till now. I've seen the midodrine. I also saw one patient, the next drug we're going to talk about, ivibradine, which I believe, I mean, you might correct me. I thought this was like for heart failure or something. Is that correct? Or like the congenital cardiomyopathy or something? Is that correct?
Yes, it's a drug used mainly by cardiologists. It blocks the funny channel in the heart. And there's substantial anecdotal evidence for it to be helpful in treating POTS.
Really?
It helps to control the heart rate. I don't think it's yet approved for that indication, but anecdotally, we see a lot of patients who benefit from it to keep the heart rate under control.
What about
this patient was on several medications. That's an indication of how hard it can be to treat.
Yeah, that's what I wanted to ask you, and I was going to ask you about 2 other medications. Like, do you normally, I would make sense, like to do this sequentially to see how they do on one drug, or does typically a patient need 2 or 3 drugs? Because I haven't seen that either in my practice. It seems like, the doctors are trying one angle, whether it's midodrine, or I've seen, as I said, a patient with vibradine. I haven't seen pyridostigmine, or do you start to pile on almost like blood pressure or something else, more drugs if you're not getting the response? Because obviously you have to start dealing with side effects when you.
Well, there are different philosophies in treating it, and I think
what's yours? You're the expert. You're the smartest doctor in the room today.
For most patients, I start with conservative treatments, salt, making sure they're well enough hydrated.
Okay.
Some people use compressive garments I find that the compressive stockings are usually not very well tolerated in
They are
Florida
not.
heat and
They are
humidity.
not. Oh, they're not tolerated in New York either. We have a lot less heat. Okay. What
So
about also droxy-dope? I believe that's a newer one. You didn't mention that in the article, but I have investigated that because as I said, I've had some patients that have been very difficult, and I believe that's like a norepinephrine. I'm not sure if it's an inhibitor or agonist, but it's been indicated. Do you have experience using that? Do you like that one at all?
I do. We were involved with the droxidopa study. It's indicated for treating neurogenic orthostatic hypotension.
Yeah.
There is some small amount of anecdotal evidence that it can be helpful in POTS. I don't have personal experience using it to treat
Okay.
POTS.
Mm-hmm.
It's a norepinephrine prodrug, so it
Like an
enhances
agonist. It
the
helps. It helps. Mm-hmm.
it enhances the supply of norepinephrine.
Mm-hmm. Okay. What about also one other angle I like to check because I think it gets way overlooked. I always say that, the adrenal gland is one of the what's the right term? It's underappreciated. Because for thyroid, it's pretty easy. Our blood testing is considered pretty accurate, and getting free thyroxine and levels in TSH. But there's always been this mystery around the adrenal gland, and I always felt a lot of patients with chronic fatigue had some kind of dysfunction with the adrenal gland. And what I try to do is I'll measure, like I know you evaluate your patients, like with AM cortisol levels to see if there's any evidence of insufficiency or failure. But have you found also the drug Florinef helpful at all in some of these patients with the orthostatic hypotension?
Yes, the AM cortisol is what I use to screen for adrenal insufficiency. And in someone who's on Florinef, the AM cortisol can be suppressed. So that's something to be aware of.
I'm sorry to interrupt. What would concern you? Because I know they really don't give good levels. I mean, I've been taught a little bit like if the AM cortisol level is less than like 5 or 6, is that would concern you? I mean, if it was like 8 or 9, is that okay? I mean, because a lot of times with the labs, they don't really give. They won't say. And when you get the report back from the lab, the cortisol comes back 5, or else even the aldosterone is 4 or 5, and they won't flag that. They'll just say because like 0 is considered to be. And I haven't seen anybody with 0 yet. So
Well, I've talked to our endocrinologist so that we have a common approach to this. So what I usually do is if it's in the level of 5 or so, I'll just repeat it on another day. And
okay, and let's say it's 5 again. Would you give the person a trial to see that there might be some adrenal insufficiency?
then I might proceed to a cortisone stimulation test to see if it
Okay,
responds to stimulation.
okay, okay. One other thing you're bringing up, and I want to touch on this because it's going to go into our next case, which is also really important. But you bring up something very interesting. It's funny. Somebody else had brought up to me before too. This whole thing about leg stimulation. That our blood is pumped back to our heart from our leg muscles, and obviously in these patients, they're pooling volume down in their lower extremities, and they don't have the ability through their autonomic nervous system to send it back up to the heart. Would it make sense in any of these patients to have? I know they do this for people recovering from like knee or different kind of surgeries, where there's some type of electrical like TENS stimulation of the muscles to get the circulation, whatever, to strengthen the system. Has that been explored at all?
I suppose theoretically you could stimulate the muscles in the leg with electricity to
Yeah,
contract, but that would probably be a little
temporary.
painful. It's much
Mm.
simpler just to engage in physical exercise.
Yeah, but
And
some of them, but as you know, some of them, Dr. Cheshire, can't because I mean, they're sort of, you know, chair bound, or bed bound. These are people that I don't know how they exercise. I mean, unless it's like on a reclining bicycle or whatever, they can't exercise. They can't stand.
well, you're quite right. And if you've not been exercising, you lose muscle mass
Right. That's it.
progressively.
Right. It becomes a double whammy.
It
Right.
just makes the situation worse. So
Right.
we find that a lot of patients with POTS really do have difficulty doing even simple exercise. And the secret is to start at a level that they're comfortable doing and build on that and gradually work up to where they're able to exercise. And we like to see them do things that will strengthen the leg muscles, to improve that venous return and also develop some aerobic conditioning. We have a POTS treatment program at our institution, both here in Florida and in Rochester, Minnesota, that helps patients to achieve that. We have an exercise physiologist that works with them to individualize a program. Some people have to start simple, which might be in a swimming pool or with a recumbent exercise bicycle. Could be a lot easier to use than an upright bike.
Right.
There's some ways of developing a program, and we found this to be very helpful in getting people literally back on their feet.
Yeah, no, that sounds like a great center to have that available to them. I'm going to go into one other case, which is in a different article that you had sent me. I thought it was important because it's so common. It was obviously the pre-COVID issue. So I would say, again, for the listeners, describe the case, and I want to just get some of your thoughts on the approach. You mentioned in a case that I guess you had seen, you wrote up about, there was a 51-year-old female that had dizziness when standing, especially first thing in the morning when she went to shower or dress. There was no relationship to this dizziness to head movement, so it wasn't like it was vertigo. She was a type 2 diabetic for 10 years. She was on a medication called amitriptyline, 50 milligrams, which she took at bedtime, which is not uncommon for these patients because she had burning feet, due to her diabetes. When you reported in the examination, she had an absent Achilles tendon reflex. So for our listeners, that's important, showing that the lower extremities, something neurological was off. She had a decreased sensory pinprick around her calves, which again, good neurologists are evaluating to see where is sensation being lost. She did have normal strength, so she was able to lift things. She had normal eye movement, no evidence of what we call nystagmus, the eyes jutting to one side. Her blood pressure lying was 140/86, but seated it was 132/84, and then standing it was 90/62. Her heart rate stayed steady in the 80s in all positions. She had normal blood sugar. She did have an elevated hemoglobin A1C. You mentioned in there, which I'm not really familiar with, something called the QSART, the pseudomotor axon reflex test. Maybe you could explain. And one other thing which I really always try to understand more about is you mentioned that her heart rate variability was subnormal for her age. And we've talked a lot on this podcast before. We keep on hearing all these terms that heart rate variability is very important for your health. And that, in fact, even in autoimmune disease and other things, it's subnormal, whereas in really healthy people, there's a good variation. And now also, I think one of my more recent podcasts, so I think there's a Whoop device I spoke to somebody about or whatever. All these things now, supposedly you can measure, but I want to hear if that's also really accurate. So can you tell us about the KSART test and then talk about the HRV?
It sounds like the case you're describing. I don't remember what paper that came from. It sounds like this patient probably has a diabetic peripheral and autonomic neuropathy.
Right. Yes. That was the case that you were highlighting. Sure. Yes.
And so one of the things that we do to evaluate a neuropathy affecting the autonomic nerves, we want to localize and grade the severity of a neuropathy and see if that's, in fact, is what we're dealing with. So we have a battery of tests in our laboratory that includes not only the tilt table test, but other tests of autonomic nerves. The QSART is a test of the postganglionic sympathetic nerve that goes to the sweat glands, the pseudomotor nerve. And we have a non-invasive way of assessing that. It's a way of measuring the small nerve fibers. You're familiar with an EMG. We look at nerve conduction studies. Those look at the large caliber nerve fibers that go to muscles. But the autonomic nerves are small caliber unmyelinated nerves. And this is a specific test that looks at that population of nerves, specifically going to the sweat glands. We look at 4 standard sites, so we can tell if there's a length-dependent distribution of a deficit and see if basically those nerves are working. Heart rate variability in our lab, we look at the heart rate response to standardized deep breathing at a pace rhythm of 5 to 6 cycles lying down. There are standard values for that. It is often decreased in autonomic neuropathies. And we look at the heart rate and blood pressure responses to a Valsalva maneuver. So the patient's straining against resistance That increases the intrathoracic pressure, which then decreases venous return to the heart. And then once the patient relaxes and blood flow to the heart is restored, we're watching the sympathetic nervous system response to that stimulus to see how robust it is.
I had a patient I actually went with to the Autonomic lab at NYU, and they had him put his feet on, it looked like a scale. I'm not sure I'm giving the right, but what it described was I guess the autonomic reactivity in he was a diabetic with lower extremities, and it was very poor. Do you know the name of that test? I was just curious. Does that ring a bell? It's like you put your bare feet on it, and it basically showed, like in a colored graph I saw on the screen. I think the autonomic nervous system response, the activity, and it showed minimal, which unfortunately was not great for the patient.
I don't know what they're using at NYU. I know that they do use the QSART as well as other tests.
No.
But there are any number of ways that you can measure autonomic reactivity. Variations in skin temperature is another, but it has a lot of false positives. So it's important to have standardized and well-calibrated testing.
What is I'm going back to my anatomy days. We know that I guess around the carotid artery, there's like some type of network of nerves. Like, what is it called? I forgot the name of it, juxtatibular, like bodies or something, carotid bodies.
The carotid body and
the carotid body, which is in the neck. It's like
the
it's
carotid
located
plexus.
The plexus, yes.
Is that artery?
Right? What role does that play in blood pressure? I mean, I assume we know that it does, because if you compress it, you can obviously, you're hitting the carotid artery. But does that play a role in any of these autonomic conditions?
It plays a crucial role.
Oh, really? Okay.
Yeah, there's a baroreceptor in the carotid sinus that senses stretch of the carotid sinus with every heartbeat.
Yeah.
And that sends a signal to the brainstem. The brainstem then interprets that to get a sense of what the blood pressure is doing in the periphery. Is it going up too fast or dropping? And then the brainstem, if everything is working properly, sends a signal to the sympathetic nervous system to tell the blood vessels what to do, to tell the heart what to do, to maintain a steady blood pressure. In someone who's had radiation to the neck that has wiped out the carotid baroreceptors, and this could be someone who's had squamous cell carcinoma of the tongue or the larynx.
Oh, wow.
Years later, that system starts to malfunction, and the brainstem is no longer getting reliable signals because the reflex from the carotid artery is absent. So the brainstem then sends erratic signals to the peripheral blood vessels and to the heart, and you can have very labile blood pressure. In fact, some patients have very sharp elevations as well as orthostatic hypotension. So that blood pressure lability can be very challenging to treat.
The reason also I bring it up, I've done on prior podcasts because it really fascinates me. I'm very interested in vagal nerve stimulation. It's interesting, I had Peter Stats on the podcast. He was originally at Johns Hopkins, and now he's in New Jersey. He started this company called GammaCore, where they use a vagal nerve stimulating device. It's been approved for migraines, but Kevin Tracy, who I've had on the podcast, who's kind of a well-known neurosurgeon in New York and researcher, did a lot of the original work showing how it's fascinating how the nervous system interplays with the immune system. And through vagal nerve stimulation, they were actually able to control autoimmune diseases. I was curious if you also have looked into any of this, like, using vagal nerve stimulators at all for any of these type of disorders.
I have colleagues in my department that are using vagus nerve stimulators to treat refractory epilepsy. I don't have personal experience in the autonomic realm. What I am aware of vagal nerve stimulators is that they affect not just the vagus nerve, but have interactions with other areas of the brain. So it's a very complex system. And the vagus nerve, as you know, the vagus meaning wanderer in Latin, it goes to the heart,
Oh yeah, it's just it
stomach,
follows all the yeah.
all over the place. Yeah.
Is it considered a combination of was it considered a parasympathetic nerve and both a sympathetic nerve?
It's a parasympathetic nerve, and it's also an afferent sensory nerve.
Okay. The nervous system, it's funny because, we've been talking so much about drugs and pharmacology, but the nervous system is like hiring your electrician. It's an electrical system. So I always tell patients, I'll repeat myself. I always say, the different phases of medicine, we went out of the dark ages with anatomy, and anatomy led to surgery, cutting out things that were bad, etc. And then we progressed to chemistry, where we came up with all these drugs to counteract whatever the effects were of, abnormal, physiology. And I always say, I think the next evolution in medicine, hopefully, is going to be electric medicine, where we understand that the body is not just, anatomical organs. It's not just, enzymes and hormones, but it's really literally electrical impulses that are going around. And neurology is really that's the specialty where I guess people would go to first. But do you see anywhere there's being made progress? Because there's a lot of things going on with all these stimulating devices, for pain and
Well, the brain is at one level electrical, another level chemical,
right.
another level psychological, and it's still the most complex structure in the known universe. That's one of the things that attracted me to neurology. I've been practicing for 34 years because the brain is so interesting, and the ways that it plays out in human lives is fascinating. But there's still so much that we don't know about it.
So as we conclude, I'd like to ask you, I mean, of course, anyone who's listening who has a friend or a family member with any of the conditions we spoke about, we always like to give them hope. So what would your words be to them about if they have a friend or family member suffering with POTS or postural orthostatic hypotension, to give them hope?
Never lose hope. And there are times in our lives when we do need help from other people, from experts, from family and friends. It's important to have a supportive structure of friends that can help you through these times. And many of these autonomic disorders can be managed, can get better. There are some devastating diseases that we see also, but there also, don't give up hope. Work with your physician, your nurse. We want to work with you. We want to partner with you and work collaboratively to help you, give you the best possible quality of life. It can be very challenging, but I think the relationships that we have with our patients are valuable, and it's a very important part of what we do.
Do you have any stories that I hate putting you on the spot, but I have to. Do you have any stories where like somebody who was really in a bad situation and all of a sudden years later, did a lot of the work through medications, came back and said, "Oh my God, Dr. Cheshire, you're not going to believe it. I was able to play in this tennis tournament, or I finished this bike race," or something of that nature. Does anything like that come to mind, or is just essentially hoping to have just a little bit better quality of life?
I got this letter out of the blue from a patient that I hadn't seen in several years with POTS, come to think of it. And she sent me this picture of her, a picture of her in the local newspaper, a star athlete in her particular sport. And she gave all the credit to me. It wasn't my doing, but somewhere along the way, I helped her to be able to function again. And she
That's
was
great.
just doing great. And we'd like to hear from our patients that we haven't seen in a while who are doing well. We'd like to know what the outcome is,
Yeah, no, it's
especially when
great.
it's a good outcome.
Of course, inspiring stories, we all want them because, as much as we like, rigorous medical studies, it's never bad to have a nice anecdotal story of somebody who's done wonderfully. Well, anyway, Dr. Cheshire, thank you so much for taking the time out of your busy schedule. This was so important. I hope anyone, as I said, listening that has a friend, family member, or is a sufferer with this condition will listen and get help to improve the quality of life. So thank you again.
I hope so too. Thank you very much.